Hello, good day. We are the first year medical student of Iloilo Doctors College of Medicine, and today we are going to perform the physical examination of the abdomen. It is important to begin with the general examination of the abdomen with the patient in a completely supine position. The presence of any of the following signs may indicate specific disorders. Distension of the abdomen could be present due to small bowel obstruction, masses, tumors, cancer, hepatomegaly, splenomegaly, constipation, abnormal aortic aneurysm, and pregnancy. The presence of any abnormal masses may indicate umbilical hernia, ventral wall hernia, femoral hernia, or inguinal hernia, depending on the location. Physical examination of the abdomen is done by inspection, palpitation, percussion, and auscultation.
Auscultation of the abdomen should occur before palpation. Otherwise, stimulation of the bowels may trigger a false increase in peristalsis. Bowel sounds are physiologically heard as clicks and gurgles in an irregular pattern. Hypoactive or absent sounds can indicate a paralytic ileus. Hyperactive sounds may indicate gastrointestinal infection or trying to overcome obstruction. Listen for possible renal artery bruits bilaterally from this area. An aortic bruit due to an aneurysm or stenosis may be auscultated at the upper umbilical area. Assessing percussion sounds is helpful in determining the size, position, and density of abdominal contents. Solid organs, fluids, or tumors lead to dull sounds that may sound similar to percussion sounds of the thigh. In contrast, the percussion sound of hollow, air-filled intestines is more drum-like in nature and is therefore known as tympanic or tympanitic. Tympanitic sounds are even more extreme in conditions involving the accumulation of excess gas within the bowels, as seen in abdominal bloating.
Good afternoon, ma'am. Ako na si Lisa Stanislao, first-year medical student from Iloilo Doctors College of Medicine, and I will be performing physical examination of your liver through palpation. Will that be okay, ma'am?
Yes.
May I ask for your name, ma'am?
Giselle.
Okay, thank you, Ma'am Giselle. So let's proceed to our examination. Hi, ma'am. It's me again, Lisa, your physical examiner for today, and we will now start the procedure of palpating your liver. May I ask you to please lie down, ma'am? Palpation. Place your left hand behind the patient, parallel to and supporting the right 11th and 12th ribs and adjacent soft tissues below. Remind the patient to relax on your hand. By pressing your left hand upward, the patient's liver may be felt more easily. Place your right hand on the patient's right abdomen with fingertips well below the lower border of liver dullness. Ask the patient to take a deep breath. When palpable, the normal liver is soft, sharp, and regular with smooth surface.
The kidneys are retroperitoneal and usually not palpable, but learning the techniques for the examination helps you distinguish enlarged kidneys from other organs and abdominal masses. Palpation of the kidney. Move to the patient's left side. Place your right hand behind the patient just below and parallel to the 12th rib, with your fingertips just reaching the costovertebral angle. Lift, trying to displace the kidney anteriorly. Place your left hand gently in the left upper quadrant, lateral and parallel to the rectus muscle. Ask the patient to take a deep breath. At the peak of inspiration, press your left hand firmly and deeply into the left upper quadrant just below the costal margin. Try to capture the kidney between your two hands. Ask the patient to breathe out and to stop breathing briefly. Slowly release the pressure of your left hand, feeling at the same time for the kidney to slide back into its expiratory position. If the kidney is palpable, describe its size, contour, and any tenderness. Percussion of the kidneys. Percussion of the kidneys help assess for pain and tenderness. Assist the client to a sitting position and stand behind the client. For indirect percussion, place the palm of your non-dominant hand over the costovertebral angle. Strike this area with the ulnar surface of your dominant hand, curl into a fist. For direct percussion, also strike the area over the costovertebral angle with the ulnar surface of your dominant hand. Curl into a fist. Repeat the technique on the other kidney. You should do the percussion of the kidneys with only enough force so that the client will feel a gentle thud. Percussion is usually done at the end of the assessment.
To palpate for the spleen, have the patient lie down in a supine position and have him relax. The left hand will reach over and around the patient to support and press forward the lower left rib cage. The right hand will press in toward the spleen in below the left costal margin. Begin palpation low enough so you can detect an enlarged spleen. Ask the patient to take a deep breath and try to feel the edge of the spleen as it comes down to meet your fingertips. Note for any tenderness and its contour and the distance of the lower edge of the left costal margin. Ask the patient to turn to his right side and repeat procedure. To percuss the spleen, have the patient lie down on a supine position and have him relax. Percuss the left lower anterior chest wall roughly from the border of cardiac dullness at the sixth rib to the anterior axillary line down to the costal margin. As you percuss, note the lateral extent of the tympani. If tympani is prominent, especially laterally, splenomegaly is unlikely. Next, check for a splenic percussion sign and percuss the lowest interspace in the left anterior axillary line. This area is usually tympanitic. Ask for the patient to breathe deeply and percuss. Percussion note remains tympanitic if spleen size is normal.
Good afternoon, ma'am. Ako gali si Jaya Denise, ma'am. First year medical student from Iloilo Doctors College of Medicine. Kag subong, ma'am, mapalpate ako sa imo. Okay lang sa imo, ma'am? Okay. At least kita mo mag-umpisa. May nabatsagan ka ba lamang nga mga masakit sa imo chan prior sa imo, ma'am? Okay. So, masugod ako, ma'am.
Gentle palpation aids detection of abdominal tenderness, muscular resistance, and some superficial organs and masses. Identify any superficial organs or masses and any area of tenderness or increased resistance to palpation. If resistance is present, try to distinguish voluntary guarding from involuntary rigidity or muscular spasm.
Naman ma'am, mapalpit ako sa imo, matumok ako sa imo ma'am na medyo madalom, okay lang ma'am?
Deep palpation is usually required to delineate the liver edge, the kidneys, and the abdominal masses. Again, using the palmar surface of your fingers, press down in all four quadrants. Identify any masses and note their location, size, shape, consistency, tenderness, pulsations, and any mobility with respiration or pressure from the examining hand.
Ma'am, tapos nakita sa aton palpation, damo gid nga salamat.
Always practice proper hand washing before doing any physical examination or assessment to your patients. For the assessment of the appendicitis, first is the rebound tenderness. Mop the area using palpation. Press down with the fingers slowly. Next, withdraw your fingers quickly. Watch the patient for signs of pain. Ask the patient if it hurt more when you press down or when you let go. Have the patient point to where it hurts. Rebound tenderness is present when there is pain with the withdrawal of the hand. The pain is caused by the movement of the peritoneum. Next is the Rovsing sign. A Rovsing sign is positive when pain is felt in the right lower quadrant when pressure is applied to the left lower quadrant of the abdomen. Referred rebound tenderness is when the patient has pain on the right side when pressure is applied to the left side of the abdomen and withdrawn quickly. Both of the signs indicate appendicitis. Next is the psoas sign. The psoas sign checks the iliopsoas muscle for irritation. Place the patient in a supine position. To perform the psoas sign, place your hand on the patient's thigh just above the right knee. Have the patient raise the right leg against your hand. Push against the patients as they try to raise their leg. This test is positive if the patient feels pain. Next is the obturator sign. This test is performed to assess the obturator muscle for irritation. Place the patient in a supine position. Flex the patient's right leg at the hip while the knee is bent at a 90-degree angle. Grab the patient's right knee and the right ankle and rotate the leg internally at the hip. This stretches the obturator muscle. If the patient has pain in the hypogastric or suprapubic area, this is a positive obturator sign. For assessment of possible ascites, first is the bulging flanks. With the patient supine, the examiner visually observes whether the flanks are pushed outward, presumably by large amounts of ascitic fluid. Please note that a patient with an obese abdomen may also have flanks that bulge, although the fat of obesity extends further posterior than fluid in the peritoneum. Second is the flank dullness. The patient is examined in the supine position. Direct percussion is done over the abdomen from the umbilicus to the flanks. The location of the transition from tympani to dullness is noted. Please note that the tympani over the umbilicus occurs in ascites because bowel floats to the top of the abdominal fluid at the level of the fluid meniscus. And lastly, the shifting dullness. This maneuver is performed with the patient supine. Percuss across the abdomen as for flank dullness with the point of transition from tympani to dullness noted. The patient then is rolled on his or her side away from the examiner, and percussion from the umbilicus to flank area is repeated. Please note that the shift in zone of tympani with position change will usually be at least 3 cm when ascites is present.